Welcome back to the Deep Dive. Today, we're turning our attention to a piece of biological machinery. That is, it's arguably the most versatile, yet also one of the most structurally compromised engineering feats in the entire human body.
That's a great way to put it.
It's the tool you use to throw a fastball, paint a ceiling, reach into the backseat of a car, or, just brush your teeth. But for millions of people, that versatility comes with a grinding, catching, agonizing price tag. We're talking about the shoulder.
It really is the classic engineering trade-off, isn't it? You can have stability or you can have mobility. And in the human body, you very rarely get both for free.
And the shoulder chose mobility.
Oh, it went all in on mobility, all in on range of motion, and it paid for it with a very steep price in terms of vulnerability.
Specifically, we're tackling a condition called shoulder impingement syndrome. Now, I want to address you, the listener, right now, who might be thinking, okay, I'm not a baseball pitcher, I'm not a quarterback, I don't swim competitive laps, so this probably doesn't apply to me.
Right.
I need to stop you right there.
Yeah.
Because looking at the research stack we have today, specifically this really comprehensive paper titled Optimal Management of Shoulder Impingement Syndrome by Escamilla and his colleagues, we found something that honestly, it stopped me in my tracks.
Yeah.
This is absolutely not just an athlete's problem.
Not even close. In fact, if you sit at a desk for 8 hours a day staring at a screen, you might actually be at a higher risk and arguably in a worse position for recovery than the guy throwing in the major leagues.
And that really is the mission for this deep dive. We're going to unpack this paper to understand the biomechanics, the why, behind the pain. We're going to debunk some pretty pervasive myths about blood flow and healing that I honestly believed until I read this stuff.
Me too.
And we're going to walk through a very specific, science-backed roadmap to fixing it, largely without surgery.
It's a roadmap that treats the body like a machine. It's all about leverage and spacing and fluid dynamics and timing. It moves us away from this vague idea of my shoulder hurts to a precise understanding of my humerus is crashing into my acromion because my scapula didn't rotate properly. It's that specific.
So let's start with the hook then. Why is the shoulder so prone to this? Why is impingement one of the most common orthopedic complaints in the entire world?
Well, if you strip it down to the basics, it's a design flaw or maybe a risky design choice by evolution.
Okay.
The shoulder is often described as a ball and socket joint, like the hip. But that is incredibly misleading.
How so?
The hip is a deep socket. The ball, the head of the femur, fits snugly inside this deep, bony cup. It's incredibly stable. You have to work really hard to pop a hip out of place.
Right, but the shoulder isn't like that.
Not at all. The shoulder is more like a golf ball sitting on a tee.
A golf ball on a tee. I like that.
The socket, which is called the glenoid, is very shallow, and it's really small compared to the size of the ball, the humeral head.
So it's unstable by design.
Inherently. So to keep that ball on the tee while you're waving your arm around, we have to rely on this complex system of soft tissue muscles, ligaments. But here's where the impingement part comes in. Above that ball, there is a rigid arch made of bone and ligament. We call it the roof.
Okay, so we've got the floor, which is the tee, the socket, and then this roof, this arch. And I'm guessing the problem is what happens in the tunnel between them.
That's it, exactly. It is a spacing issue. Running through that tunnel between the roof and the floor are the rotator cuff tendons, specifically the supraspinatus tendon, and a little fluid-filled sac called the bursa.
Sounds crowded.
It is a very crowded tunnel. And when you raise your arm, that space naturally narrows. If everything is working perfectly, you have just enough clearance. We are talking millimeters.
How many millimeters?
About 5 to 10. That is your margin of error.
5 to 10 millimeters. That's less than the width of my pinky finger.
Exactly. And if your mechanics are even slightly off, or if that space is just anatomically tight, the roof basically crushes the tendon every single time you move.
Wow. That creates a really visceral image. The roof crushing the tendon. Is this what the paper refers to as subacromial impingement?
Correct. That is the main one, the most common type, and that's really the focus of our deep dive today. There is another type they mention, internal impingement, but that's a slightly different beast.
Let's just distinguish those quickly so if you're listening, you can figure out which camp you might fall into.
Sure. So internal impingement is almost exclusively an overhead athlete's problem. So think of a pitcher cocking their arm way, way back, that extreme external rotation, hand behind the head.
The throwing position.
The classic throwing position. In that specific position, the undersurface of the rotator cuff gets pinched against the lip of the socket itself, the glenoid rim. It's a pinch happening inside the joint.
Okay.
But for the vast majority of people, the "I hurt my shoulder lifting a box," or "my shoulder aches at night," or "I can't put my jacket on without wincing" crowd, we are almost always talking about subacromial impingement, the crushing from above, under that arch.
So let's deep dive into part one of our breakdown here. Deconstructing the machine. The paper mentions this roof is called the coracoacromial arch. I mean, it sounds like a piece of Gothic architecture.
It basically is. It's formed by the acromion process. That's that bony shelf you can feel on top of your shoulder, and the coracoacromial ligament that connects it to another bony point called the coracoid process.
So it forms a bridge.
A bridge, exactly. A rigid, unyielding bridge.
And underneath that bridge lives the victim.
The supraspinatus tendon. And it has to glide back and forth under this arch thousands, maybe tens of thousands of times a day. Every time you lift your arm, that tendon slides.
You mentioned 5 to 10 millimeters of clearance. I mean, it just feels like bad engineering to have such a vital moving part in such a tight squeeze. Why is it built like that?
It's that trade-off again. It's for leverage and for the ability to raise your arm above your head. The acromion provides a lever arm for the deltoid muscle, but because that space is so tight, the entire system relies on perfect centering.
Perfect centering.
Yeah, if the ball rides up even a little bit, or if the roof slopes down, you have a collision. And think about this. If that tendon swells even a tiny bit from overuse, it takes up more space, which makes the next collision even more likely.
It's a feedback loop.
A terrible one.
So does this damage happen all at once, like I reach for a book and snap? Or is it more of a slow burn?
That is the tricky part, isn't it? It is usually a slow burn that you ignore until it becomes a snap. The paper references a classification system that was developed by a surgeon named Charles Neer way back in 1972.
Right?
And it's almost like a life cycle of the injury. It maps the progression of the disease over time.
There's 3 stages.
Yeah.
I found this part fascinating because it maps so well to different age groups, which, usually suggests a wear and tear component.
It definitely does. So stage 1 is typically seen in people under the age of 25. This is the acute phase. You have edema, which is just swelling, and maybe some hemorrhage, some bleeding in the tendon.
So this is the college athlete or the young person who helps a friend move a couch over the weekend and then wakes up sore.
Exactly that. They overdid it. The tendon got pinched, it got irritated, it swelled up. But the key characteristic of stage 1 is that it is reversible.
Okay, that's good news.
It's basically a bruise inside the tendon. It hurts, it aches, maybe you lose some range of motion because of the pain, but the actual collagen structure of the tendon is still intact. If you rest it and treat it, it can go back to normal.
Then we hit stage 2. This seems to be the danger zone where people get stuck.
I'd agree with that. Stage 2 is typically ages 25 to 40. Now, the repetitive trauma isn't just causing swelling anymore, it's starting to cause fibrosis.
Fibrosis.
The tendon is getting scarred and thick, and the bursa, which is supposed to be this thin lubricating cushion, that gets thick and fibrotic too.
Which creates that vicious cycle you just mentioned, right? Because if the tendon gets thicker from the scarring...
It takes up more room in that already tiny tunnel.
Exactly. The tunnel is fixed at 5 to 10 millimeters. If the resident of the tunnel gets fat from inflammation and scarring, the tunnel effectively gets smaller.
Which means more rubbing. More rubbing, more inflammation, more thickening. This is where you see pain with activity that starts to become chronic. It's not just, I overdid it yesterday. It's, my shoulder always hurts when I do this one thing.
And then we have stage 3. This is the over 40 category.
Unfortunately, yes.
Yeah.
Stage 3 is where we see permanent structural changes. Bone spurs, they're called osteophytes, start to form on the acromion.
On the roof.
On the roof. The body is trying to reinforce the bone because of all the friction, but it ends up turning that smooth roof into a jagged cheese grater.
Cheese grater is a terrifying description for a bone inside my body.
It is, but it paints the picture perfectly. You have a rope, the tendon rubbing against a sharp rock, the spur. Eventually, that rope is going to fray.
And that's where you see the tears.
That's where you see partial and then eventually full tears of the rotator cuff. And once it tears, the mechanics are just completely broken.
But here is the stat that I alluded to in the intro, and I want to make sure everyone listening really absorbs this because it completely flips the script on who gets this injury. Neer reported that 70% of rotator cuff tears they occur in sedentary individuals.
70%. It flies in the face of common logic, doesn't it?
It really does.
We think of rotator cuff tears as a baseball injury, a tennis injury, or maybe, a construction worker's injury. But the data says 70% are sedentary, people who are not throwing fastballs for a living.
So why? Is it just that the machinery rusts if you don't use it? Or is it something more active?
It is a combination of both degeneration and bad mechanics, and the paper highlights this beautifully. You don't need to be throwing a 90-mile-per-hour fastball to impinge that tendon.
Right.
If you are sitting at a desk with rounded shoulders for 10 hours a day, you are actively narrowing that subacromial space. You are changing the angle of the roof.
So by slouching, I am clamping down on the tendon.
Essentially, yes. When you round your shoulders forward, your shoulder blade, your scapula, it tilts anteriorly, and that brings the acromion, the roof, down. So you are just sitting there, typing away with the roof lowered onto the tendon. You're compressing it statically for hours.
And then when you finally do reach up to grab something.
Exactly. You reach for a coffee mug on a high shelf, or you put a bag in an overhead bin on a plane. The tendon is weak from disuse, the space is already compromised by your posture, and failure occurs.
So the weekend warrior who does nothing all week and then goes and plays softball on Saturday is essentially setting a trap for themselves.
Precisely. They have the stage 2 or stage 3 degeneration from sedentary living, the rust, if you will, and then they apply a high dynamic load to it. It is the perfect storm for a tear.
Let's move to part 2, the why. The paper distinguishes between structural and functional factors. This is kind of the nature versus nurture of shoulder pain.
That is a great way to put it. Structural factors are the hardware issues. It's the shape of your bones. Functional factors are the software issues. It's how you move and stabilize those bones.
Okay, let's talk hardware first. The shape of the acromion. That roof bone matters a lot. I didn't realize there were different types.
It does. It matters a great deal. The study breaks down 3 types of acromions based on their shape. Type 1 is flat. That's the good one. That's the one you want. It gives the most space.
A high ceiling.
A high, flat ceiling. Then you have type 2, which is curved, so it dips down a bit. And then you have type 3, which is hooked.
And I'm guessing hooked is the one you don't want.
Definitely not. The stats they're staggering. The paper notes that 70% of rotator cuff lesions are associated with a hooked type 3 acromion. It literally digs into the tendon like a claw.
Wow. Is that genetic? Are you just born with a bad roof?
The underlying shape is largely congenital, yes. You get the bones your parents gave you. But bone spurs, which can turn a perfectly good type 1 into a jagged mess that acts like a type 3, those are acquired through age and friction.
I see.
But here's the key. We can't easily change your bone shape without surgery. And that's why the paper focuses so heavily on the functional factors, the software. Because that we can change.
And the biggest software bug seems to be what they call the self-perpetuating process of instability.
This is the death spiral of the shoulder. And to understand this, we have to really understand the job of the rotator cuff. Everyone thinks the rotator cuff lifts the arm.
And it doesn't.
It doesn't. The big muscle, the deltoid, that lifts the arm.
Then what does the cuff do? Why do we spend so much time rehabbing it?
The rotator cuff's primary job is to pull the humeral head down and keep it centered in the socket while the deltoid is pulling it up. It's a stabilizer.
Okay, an analogy maybe.
Think of it like this. The deltoid provides the power to move a lever. The rotator cuff provides the fulcrum. And if you don't have a stable fulcrum, the lever just jams.
So if the cuff is weak?
The deltoid wins the tug of war. The deltoid's line of pull is upward. So without the cuff holding that ball down, the deltoid just pulls the arm bone straight up, jamming it into the roof.
And that causes the impingement.
That is the impingement. And the impingement causes pain and damage. The pain then causes more weakness because you don't want to use it. And the cycle just accelerates.
That makes so much sense. It's a tug of war. And if the stabilizer, the little guy loses, the big guy crashes the joint.
Exactly. And then you add in something called capsular tightness. This is a huge one in the paper, and it's one of the most common things physical therapists find. Specifically, tightness in the posterior capsule, the back of the shoulder joint envelope.
Okay, this part was counterintuitive to me.
Yeah.
If the back of my shoulder is tight, wouldn't that pull my shoulder back? That sounds like a good thing for posture, but the paper says it makes things worse.
It's weird mechanics, right? It's not intuitive unless you understand arthrokinematics, how the joint surfaces move on each other. Think of the shoulder joint like a ball spinning on a plate. If the back of the capsule, the envelope surrounding the joint, is tight It acts like a wall.
A wall behind the ball.
Yes. And when you try to move the arm, that tight wall pushes the ball forward and upward.
Like squeezing a watermelon seed between your fingers. It shoots out.
That's a perfect analogy. As you lift your arm, that tight posterior capsule pushes the humeral head superiorly upwards, right into the acromion. It forces the collision.
So a tight back of the shoulder equals a smash top of the shoulder.
Correct. And that's why, as we'll see in the rehab section, stretching the back of the shoulder is a key to fixing pain in the top of the shoulder. It creates room for the ball to stay centered.
Okay, then there is scapular dyskinesis. This is all about the shoulder blade.
The scapula is the foundation. It's the platform that the arm worked off of. If you raise your arm, your scapula has to rotate upward to get out of the way.
Like what?
It's like opening a gate before you try to drive the car through.
If you have dyskinesis, which I guess just means bad motion.
The gate stays closed, the scapula stays put, or it moves too slowly, or it moves in the wrong direction. You try to raise your arm, and the arm bone just hits the stationary scapula. Boom. Impingement.
And posture plays a huge role here. The rounded shoulder look.
The classic desk worker posture, forward head, rounded shoulders that increase thoracic kyphosis or hunchback. This posture tilts the scapula forward, which effectively lowers the roof before you even try to move. You're starting at a huge disadvantage.
You can feel that.
Yeah. Try it right now. Slouch and lift your arm as high as you can. It gets stuck.
It does. It just stops.
Now sit up tall, pull your shoulders back, and lift it.
Wow, it goes way higher.
That difference.
Yeah.
That is the impingement zone you just created with bad posture.
I want to move on to part 3 because this is where I had my real mind-blown moment reading the source material. It's about blood flow. I've always heard that tendons don't heal well because they don't have good blood supply. The whole white tissue versus red tissue thing. But this paper basically calls that a myth.
Well, a partial myth. For a long, long time, standard medical teaching was that the critical zone of the supraspinatus tendon, the part that usually tears, was avascular, no blood, therefore no healing.
Right, that's what I thought.
But newer studies, and they're cited in this paper using things like laser Doppler flowmetry, they show that there is blood flow there. There are connections, they're called anastomoses, between vessels from the bone and vessels from the muscle. It is not a dead zone.
There's a catch, and it's a big one.
There's a massive catch. The blood flow is position dependent, and this is what they call the wringing out effect.
This image stuck with me, like wringing out a wet towel.
Exactly. The paper cites a classic study by Rathbun and McNabb, and they found that when the arm is resting flat at the side, what we call adduction, the tension on the tendon literally wrings the blood vessels dry. It squeezes them shut.
Okay, wait, I need to clarify this for myself and for everyone listening. If I have a sore shoulder, my instinct is to hold it tight against my body. I let it hang limp at my side to rest it.
Right.
You're saying that position, the resting position, is actually cutting off the blood supply that it needs to heal.
That is the paradox. When your arm is perfectly flat against your body, that critical zone gets almost no blood. This has huge implications for sleep and for rehab. If you sleep on your side with your arm crushed under you or just flat at your side, you are starving the tendon all night long.
So what's the fix? How do we keep the blood flowing to it?
You need a little bit of abduction, moving the arm slightly away from the body. Even just a small angle opens those vessels back up.
So if I'm sitting in a chair watching TV with a hurting shoulder.
Put a small pillow under your armpit. Or rest your arm on the armrest so it's propped out a bit. Just don't let it hang heavy and flat against your ribs. That wringing out phenomenon is a major reason why these injuries become chronic. We are literally starving the tissue of the nutrients it needs to repair itself.
That is a massive, actionable takeaway right there. The pillow trick.
It's so simple, but it's based on hard vascular science. The paper also mentions that active flexion, actually using the muscle, raises the pressure inside the tendon significantly. They measured the subacromial pressure rising from 8 millimeters of mercury at rest to 56 during a contraction.
And that also stops blood flow.
That pressure also stops the microcirculation temporarily, yes.
So exercise temporarily stops blood flow, and resting at your side stops blood flow. It seems like the tendon never gets a break.
It explains why it's so hard to heal. You have this very narrow window for perfusion. You need the arm relaxed but slightly away from the body. That is the sweet spot for healing.
Okay, before we get to the gym and the rehab, let's quickly touch on part 4. Medical interventions. The stuff doctors do before the PT starts. The paper talks about cortisone shots. I mean, everyone I know with shoulder pain has had one.
It's the first line of defense in so many clinics. And it works for pain relief in the short term. The anti-inflammatory effect is very powerful. But the paper is quite cautious here. It notes that steroids can cause tendon ectrophy shrinking and even cellular necrosis.
Necrosis means death. That is not a word I want associated with my tendons.
No. And it can reduce the healing ability of the tendon long term. It essentially shuts down the cell machinery to stop the inflammation, but that also stops the repair process.
So it puts the fire out, but weakens the building.
That's a good way to think about it. It's catabolic. It breaks things down. It's not a long-term fix, and repeated injections are generally discouraged now for that reason.
What about PRP? Platelet-rich plasma. That's the trendy one where they spin your blood and inject the good stuff back in.
The concept is great. You're injecting your own growth factors to stimulate healing. It's anabolic. It's building things up. But the verdict in the paper is promising, but not proven.
So the jury's still out.
Yeah, the systematic reviews they cite show very mixed results. Some people get great relief, others get nothing. It's definitely safer than steroids in terms of tissue health because you aren't introducing a catabolic drug, but we just can't say for sure that it fixes the problem consistently.
And then there's something called the FAST procedure.
Focused aspiration of soft tissue. This one is interesting. It uses ultrasound to find the bad, dead, degenerative tissue, and it basically vacuums it out. It's minimally invasive, quick recovery, like 4 to 8 weeks.
Those for cleaning house.
It's an option for that fibrotic, scarred tissue we talked about in stage 2. If the tissue is dead and scarred, it's not doing any good. Sometimes you just have to remove it to let new, healthy tissue grow in.
Okay, let's get to the core of this deep dive. Part 5, the rehabilitation protocol. The paper lays out a 4-phase program. And what I really liked is that this isn't just do these exercises for 4 weeks. It's criterion-based.
Which is absolutely crucial. You don't pass to the next grade just because the semester ended. You pass because you learned the material. In this rehab, you don't move to phase 2 until you meet specific pain and motion goals of phase 1.
So it's based on progress, not a calendar.
Exactly. If it takes you 2 weeks, great. If it takes you 2 months, so be it.
So phase 1, the acute phase, maximal protection. My shoulder hurts, it's inflamed. What do I do?
Goal number 1 is calming it down. Cryotherapy ice is key here.
Is that just to numb the pain, or is there more to it?
There's more. It's not just pain. It acts as a vasoconstrictor. It reduces the metabolic activity in the area. If the cells are hyperactive and inflamed, ice slows them down. It helps control that chemical storm.
And motion is lotion, right?
Yeah.
But we have to be really careful how we move.
We do.
Huh.
We want to prevent atrophy, but we can't be crushing the tendon more. The paper talks about the reverse capsular pattern. Usually patients lose internal rotation first. That's reaching up your back and then abduction. So we need to restore that range very carefully.
They mentioned L-bar exercises, which is basically using a stick to push your arm around.
Active assisted motion. Your good arm does the work for the bad arm. But here's the technique tip that matters more than anything else. When you raise the arm overhead into flexion, you should do it with external rotation.
Why? Why does the rotation matter if I'm just lifting it straight up?
Okay, picture the shape of the humerus bone, your upper arm bone. It has a big bump on the side called the greater tuberosity. That's where the rotator cuff attaches. If you raise your arm with your thumb down in internal rotation,
Okay.
that bump smashes right into the acromion roof.
So I'm driving the bump into the bridge.
You're creating your own impingement. But if you rotate your thumb out into external rotation, that bump rotates back and out of the way. It clears the arch.
So thumb up or palm up when reaching overhead clears the bone. Thumb down causes the crash.
Exactly. It is a simple mechanical clearance issue. If you reach for something on a high shelf, do it with your palm facing you or your thumb up. Never, ever thumb down. That simple change can save you thousands of impingement events a year.
Now, stretching. We talked about that
Yeah.
tight posterior capsule. The paper recommends the sleeper stretch.
This is a staple. You lie on your side, on the injured side. Your arm is out at about 90 degrees, resting on the mattress. You use your other hand to gently push your wrist down toward the table.
That sounds like it would hurt.
It can be uncomfortable, for sure. You are stretching the very back of the shoulder joint, but it's essential to stop that watermelon seed effect we talked about earlier. You have to create space.
And the pectoralis minor. That's a chest muscle.
The pec minor is in the front. When it's tight, it pulls the shoulder blade forward and down. That's that bad posture we talked about. Doorway stretches work, but the paper notes that unilateral self-stretches are often more effective than having a therapist stretch you.
Why is that?
Because you can control the angle better to isolate that specific muscle. You can feel it more precisely.
What about strengthening in this acute phase? If moving hurts, how do we get strong?
We use isometrics. Pushing against a wall without moving, you activate the muscle, you get that neural connection going, but you don't grind the joint because there is no movement.
Okay.
And they mention rhythmic stabilization.
This sounded like a trust exercise when I read it.
It kind of is. The therapist holds your arm in what's called a balanced position, usually about 30 degrees out in the scapular plane, and then they just tap it in different directions.
And my job is to just hold still.
Your job is to not let them move you. It forces the rotator cuff to fire reflexively to stabilize the joint without any big heavy movements. It's like waking up the software. It reminds the rotator cuff, hey, your job is to hold the ball steady.
Okay, let's say we've graduated phase 1. Pain is down, motion is okay. Phase 2, the intermediate phase. Now we're building muscle. And we run headfirst into a massive gym controversy, the full can versus the empty can.
This is one of the most important takeaways from the paper for anyone who goes to the gym. For years, the gold standard for isolating the supraspinatus was the empty can exercise.
This is standing with dumbbells, arms out to the side, thumbs pointed down like you were pouring out a can of soda.
Right. It was popularized by Dr. Frank Jobe, who was a legend in shoulder surgery. And the EMG data showed it lit up the supraspinatus, it worked to isolate the muscle, but mechanically, it's a disaster for impingement.
Because of what we just said about the bump on the bone.
Exactly. The empty can position, that internal rotation, rotates the greater tuberosity right into the acromion. So yes, you are strengthening the muscle, but you are simultaneously grinding it against the bone.
They're fixing it and breaking it at the same time.
You're fighting yourself, it creates pain, and often the pain actually inhibits the very muscle you are trying to strengthen.
So the paper says, stop doing that.
Stop doing that. Switch to the full can. Thumbs up. The EMG data shows the supraspinatus activation is almost exactly the same, maybe marginally less, but it's statistically insignificant. But the clearance is much, much better. No grinding.
So thumbs up in the gym. Always.
For shoulder raises, absolutely. It is safer and just as effective. There is almost no reason for the general population to be doing empty can exercises.
Phase 2 also hits the scapula hard. We go back to the foundation.
You have to fix the foundation. We need to strengthen the retractors, the rhomboids to pull the shoulders back, and the depressors, the lower trap and serratus anterior, to pull the scapula down and help it rotate upward.
They mentioned using tactile cues like tape or postural shirts. Does that stuff actually work?
It works for proprioception. Sometimes your brain just forgets where your shoulder blade is supposed to be. You've been slouching for 10 years. Your brain thinks that's normal.
It's recalibrating.
Exactly. Having a piece of tape across your back that pulls tight when you slouch gives you that sensory feedback to straighten up. It's retraining the brain-body connection. It's not that the tape is holding you up. It's reminding you to hold you up.
And proprioception moves to closed kinetic chain. Explain that term for us.
So most shoulder exercises are open chain. The hand is moving freely in space, like lifting a dumbbell. Closed kinetic chain means your hand is fixed on something solid, like the floor or a wall.
Like a push-up.
Exactly. Wall push-ups, being on all fours in a quadruped position, or weight shifting on a stability ball. When the hand is fixed, the compression forces actually help stabilize the joint, and the mechanoreceptors, the little sensors in the joint, they fire like crazy.
So it's teaching the shoulder where it is in space.
Precisely. It's safer because the joint is compressed and stable, but it builds incredible stability.
Moving on to phase 3, advanced strengthening. Now we are getting into power and endurance. This is where plyometrics come in. I usually think of box jumps for legs when I hear plyometrics. What on earth is a shoulder plyometric?
It's the exact same principle, the stretch shortening cycle. It's all about explosive reaction.
So what does that look like for a shoulder?
Things like chest passes with a medicine ball, or dribbling a small weighted ball against a wall.
Wait, dribbling against a wall? Like a basketball?
Exactly, but at shoulder height. You throw a small, maybe 2-pound ball against the wall, you catch it, and you immediately throw it back. It forces the muscles to absorb force eccentrically, stop it, which is the amortization phase, and then return it concentrically, incredibly fast.
Why is that speed so important? Why not just lift heavy weights slowly?
Because in real life and in sports, injury happens fast. If you trip and fall, your shoulder needs to react in milliseconds to stabilize itself. Slow lifting does not train that snap reaction.
But plyometrics do.
They do. They train the neuromuscular system to react instantly.
The paper breaks down those plyometric phases.
Yeah.
Eccentric, amortization, concentric.
And that amortization phase, the transition between catching and throwing, That is the key. It has to be short. If you catch the ball, hold it, think about it, and then throw it, you've lost the elastic energy. You lost the plyometric effect.
Had us be like a hot potato.
Exactly. Catch throw. Instant.
They also mentioned the thrower's 10.
This is a legendary protocol developed by Kevin Wilk and his colleagues. It's a specific set of 10 exercises based on EMG data that targets every single muscle needed for throwing. It's the gold standard for overhead athletes.
Is it just for throwers?
It was designed for them, but it's comprehensive. It hits the cuff, the scapula, the forearm, everything. It's a great advanced program for anyone needing high-level shoulder stability.
And fatigue management. This was a scary point for me. Fatigue kills proprioception.
It does, and this is crucial for preventing re-injury. When your rotator cuff gets tired, it stops doing its main job, which is pulling the humeral head down.
So the deltoid takes over again.
The deltoid takes over, and it pulls the head up. Smash. Impingement. So the paper argues that endurance training isn't just about lasting longer in your sport. It's a safety mechanism.
Right.
If your cuff has endurance, it protects your joint late in the game or late in the workday. The moment the cuff fatigues, the mechanics fall apart.
Finally, phase 4, return to activity. This seems to be mostly for the athletes, the interval throwing program, or ITP.
It's a ladder, a very structured ladder. You don't just go out and pitch a game after rehab. You start with long toss. You throw from 45 feet, then 60, then 90. You build the distance to build the arm strength before you ever get on a mound.
And the crow hop. Why is hopping important?
It uses the legs and the trunk. It forces you to transfer energy. If you throw flat-footed, your arm does all the work. If you crow hop, your legs generate the force and the arm just funnels it, takes the load off the shoulder. It teaches the athlete to use their whole body again.
Now here is the part that made me laugh out loud. The perceived effort trap.
Oh, the Fleissig study. This is classic human psychology. It's fantastic.
They asked professional pitchers to throw at 50% effort. Just a nice, easy toss.
And the radar gun showed they were actually throwing at 83% of their max velocity.
And when they asked for 75% effort,
They hit 90%.
so basically, athletes have no idea how to take it easy.
They really don't. Their mechanics are tuned for speed. They don't know how to throttle down. It's like asking a Formula One driver to drive 20 miles per hour. They just can't feel it.
So what's the solution? If you tell a recovering patient, go easy, and they accidentally throw a rocket, they re-injure themselves.
The solution is the arc. You tell them to throw the ball with a slight rainbow arc. You mechanically cannot throw a ball 100 miles per hour with an arc. It would go into orbit.
Right.
The arc forces them to slow down and control the motion. It's a brilliant constraint-based cue. You don't trust their feeling. You trust physics.
That is smart. And then finally, weighted balls.
It's counterintuitive again. Underweighted balls, which are lighter than a baseball, train velocity and speed. Overweighted balls train strength and power. You need a mix of both for a complete, well-rounded rehab.
So we've covered the machine, the glitch, and the fix. Let's try to summarize the big takeaways for you, the listener, who is just trying to keep your shoulders healthy.
Okay, first, space is everything. Impingement is a spacing issue. Everything we do in rehab should be about maximizing that subacromial space.
Second,
Don't starve your tendons. Avoid that wringing out position. Keep a pillow under your arm or use an armrest. Don't let the arm hang flat against your body.
third, thumbs EP. The full can is safer than the empty can. Save your tendons the grinding in the gym.
Absolutely. Fourth, check your posterior capsule. If you can't reach up your back or across your body easily, the back of your shoulder is probably tight and it's pushing everything forward into that danger zone.
And finally, fix your posture. If you round your shoulders, you are lowering the roof on your own tendons.
Absolutely. The scapula needs to be able to move. If you sit tall, you open the gate. If you slouch, you lock it shut.
Here's my final provocative thought for the day. We talked about how 70% of these tiers are in sedentary people. Yet almost all the rehab protocols, the throwers 10, the interval throwing program, they're all designed for baseball players.
It's a huge disconnect. The research is driven by sports, but the victims are in the office.
So are we living in an era of office impingement? And if so, does that mean the average office worker actually needs to train like a pitcher? Do we all need to be doing plyometric wall dribbles just to survive a 40-hour work week at a computer?
You know, it's a compelling argument. We are asking our shoulders to hold a static, compromised posture for thousands of hours a year. That requires a level of endurance and stability that maybe only an athlete usually possesses. So perhaps, yes, we should all train like throwers, not to throw fastballs, but to survive the desk.
Treat your desk job like a sport and train for it. I love that. Thank you so much for breaking this down with us today.
My pleasure. It's fascinating mechanics.
And thank you for listening. Keep those thumbs up, keep that posture tall, and we will see you on the next deep dive.
Take